Hi everybody, welcome to SRH Access Live. We have some exciting news for you guys. Maggie, your weekly host, had her daughter last week, so congratulations to Maggie. Yes, they're doing well.
There's no doubt she's watching.
Exactly. Hi Maggie. Hi Margot.
It's
her new baby. So my name's Lexi and I'm going to be filling in for the next couple of months. And we're here with Dr. David Podeszwa, co-director of our Center for Excellence in Limb Lengthening. And today we're going to talk about a certain type of limb lengthening that we do here called intramedullary lengthening.
Correct.
So first, let's just talk about what is that and how does it work?
So intramedullary lengthening is a technique of lengthening a bone. And of course the muscles, the soft tissues, the muscles, the nerves, the ligaments all lengthen as well. But it's a technique of lengthening the bone using an intramedullary rod. So using a rod that goes inside the bone and lengthens it through either a magnet or electrical current, depending on the type of rod you use.
And so when do you guys use this as a treatment plan?
So this is ideal for patients that have a leg length discrepancy, usually over 4 or 5 centimeters at the time that they're done growing, or younger kids that we know that when they're done growing will have maybe twice that much, could have 10 or 12 centimeters when we think they're going to be done growing. So it requires someone who has got a large leg length discrepancy. And then it works best in patients who have straight bones, because there are certainly times when people will have a leg length difference but have deformity in their bone as well. And this doesn't work as well with deformity. So it's because it's a straight rod going inside the bone, it's best to have a straight bone to do it.
And so is this something that you can choose between this, and we've talked before about the external fixators and those frames and how that works. What's the difference kind of between those two?
Yeah, I mean, this is something that we talk about at the time that we're starting to talk about a limb lengthening and whether who's a good candidate and who's not. And obviously it's very individual. So we have that discussion because some patients, you can use both techniques. But ideally, we want to use the intramedullary lengthening if we can instead of an external fixator because we've shown that patients just do better with an intramedullary fixator from a quality of life standpoint. There's less pain involved. There's less care to the extremity. You don't have pins and wires sticking outside the leg that need to be cared for. So the discomfort of that, the discomfort of the soft tissues during the lengthening procedure is better. So patients just feel better through the whole process. It's still a risky technique. Anytime you're lengthening the bone, whether you use an external fixator or an intramedullary rod, it's still lengthening, and there are complications that can happen. But we've definitely demonstrated from a quality of life standpoint, it is a preferred technique.
And I think you have a couple examples of the actual rods?
Examples. So there's a couple different types of rods that you can use for intramedullary lengthening, but these are two different examples. Now obviously these are different sizes for depending on how big the patient is and depending on how much lengthening you need to do.
Okay.
So it's just a very simple straight rod, both regardless of what kind of rod you use. It's a simple straight rod that goes inside the bone, and you can see how there's a little joint here and there's one up in this one as well that allows the rod to telescope or to lengthen with over time. Now in this case, with this type of rod, there's a magnet inside the rod so that when it's inside the bone, you put a magnet on the skin and it slowly lengthens the rod. And you do it a little bit several times a day and lengthen the rod, so it's used a magnet. Where this type of rod uses a little transducer, and you have a little box that sends a little current to the transducer, and the transducer causes it to lengthen. It's just a different type of rod, and there's certainly indications for both, and that's what we discuss obviously when we work with patients, is what's going to be the best technique.
Very cool.
For
so
you.
The magnet one reminds me of the magic rods that we've talked about that we
Correct.
use.
Same technology as the magic rods for the spine.
All right. Very neat. And is this something that can only be used in leg length discrepancies, or do you ever use this in upper limbs?
It absolutely has been described in the use for lengthening the humerus. There are people who will have either from an infection or from trauma, may have an injury to the growth plate and a short humerus, and certainly it's been described for the humerus. Patients who have had amputations, like traumatic amputations, oftentimes their bone may not be long enough for a prosthesis, so there are ways to put it in a bone and lengthen the bone in the leg to allow for better fitting for a prosthesis. So yeah, there are other applications for it.
Great, so multi-uses here.
Absolutely.
And so do these patients have to stay in the hospital after they have one of these rods implanted? Or?
No, generally speaking, the rod goes in and the patient will go home the next day or even maybe a second night, because we will wait oftentimes a week or maybe two, depending on if we're doing the leg bone. We wait a little bit longer before we start the actual lengthening procedure.
Okay.
So once the rod goes in, we wait from anywhere from 5 days to 14 days, and then we'll have them back in clinic and start the lengthening procedure back in clinic. So it's not it's a relatively straightforward procedure putting it in, and then the hard part comes during the lengthening.
Right. And how long does that part last usually?
Of course, it depends on how much we're lengthening, but basically we tell patients that it's going to be at a minimum 6 to 9 month process, meaning having the surgery, doing the lengthening, getting the bone to heal. So you have to figure that if, let's say, 4 centimeter lengthening for that, it's going to take you basically a millimeter a day, maybe a little bit less than that, somewhere between 3/4 and a millimeter a day to lengthen. So right there, if it's 4 millimeters, you're looking at least 40 days, probably more like 50 or 60 days. So it could be a couple months to do the lengthening. Then for every centimeter you lengthen, you have to probably add on a month of healing potentially. Mm-hmm. So it could take, right there, you're at 6 months. It could easily be longer than that. Right. So it's a commitment on our part, but it's even a bigger commitment by the patient and the family to do a lengthening like this.
Right, and we touched on last time when we were talking about external fixators, how this multidisciplinary approach, how you're meeting with psychologists, you're meeting with the nurses before
Absolutely.
Something like this happens. Is this the same situation for?
Absolutely. We don't change the process in any way, and that there's a lot of education that goes in with nursing. Psychology is a big important part of this so that we can learn more about the patient can learn more about us, what we're doing, how we do it, what to expect, and most importantly, how to cope with it. And we've shown that that's been a huge part of patients doing better during the procedure, during the lengthening, and certainly afterwards as well.
Yeah, better success.
Absolutely.
Is there a certain age range of patients that get this kind of treatment, or is it kind of all over?
No, actually, patients basically starting at 8, 9, and 10 years old are candidates for the use of an intramedullary rod, depending again on the deformity and how much lengthening. We really prefer to wait until the patient is older. So if you can wait till they're done growing, it helps to know then exactly what you need to achieve.
Right.
Lengthening can have an effect on open growth plates, so we don't want to have any ill effect on that. And when the patient's a little bit older, they're a little bit more mature, and this isn't something that we do to patients. This is something we do with patients, and we need them to be engaged in what we do because they are by far the most important part of the lengthening process. They need to be engaged in physical therapy every day, doing exercises to work on range of motion, to protect their hip, to protect their knee. So if they're not engaged and not part of the process, you open yourself up to complications. So the older, more mature, if we can, if we're not forced to do something sooner, and that's pretty rare that we are, then the older the better.
Helps to get everybody on board for this
Absolutely.
process.
Absolutely.
And so what's the activity level when you have something like this? Is it weight bearing, no weight bearing?
Sure. When after we put the intramedullary rod in, we start the lengthening process. They're on crutches, basically, just resting their foot on the ground until the bone is healed, until the lengthening is completed and the bone is healed enough that they can walk on it. And again, so you're looking at potentially 6 to 9 months of being on crutches before we're letting you walk on it without the crutches. So that alone is a big commitment. And at first it doesn't seem so bad, but there's no doubt that as you get into 3, 4, 5 months go by, it gets a little trying.
It's tough, yeah.
It gets a little trying.
But you can go to school and that type of thing?
Absolutely. And just like lengthening, any lengthening procedure we do, this is not to define your life. It's not to define their daily routine, but it's to become part of it. So we make a big deal about this being a part of your normal routine. And when you're talking about a 6 to 9 month process, no matter when you do the surgery, it's going to run into the school year.
It's going to affect things.
So we want to do it so that we are ready to get you back into that routine as quickly as possible.
Great. And what kind of feedback do you get from our patients and parents throughout this process and when it's over?
Well, I can tell you that, again, we've studied this and we've one of my, we've actually published on this. Dr. Birch, one of my senior partners, has published on this in their comparison of the use of the intramedullary rod and external fixation. And the patients that have had severe deformity and have had both will come back and tell you that the intramedullary lengthening is far and away better than having an external fixator.
Interesting.
I mean, from a quality of life standpoint,
Right.
there's a huge difference.
And I want to get this right. You guys just got back from the Limb Lengthening and Reconstruction Society, or LLRS, meeting in San
Correct.
Francisco. Talk to me about some of the research that goes into this that we do here at Scottish Rite.
Well, we do. We've been doing a lot of research, not only on. This dates back many years into understanding the physiology of lengthening, both the muscle response to lengthening and the bone response to lengthening. Obviously, we have a lot of we have large clinical trials that are kind of always ongoing, looking at the clinical outcomes of patients undergoing limb lengthening, whether it be with external fixator or intramedullary lengthening, and how these patients respond. And the psychology is an important part of this, and we certainly have studied and continue to present on our experience working with kids before their treatment, during the treatment, and after their treatment, and how that affects their outcomes. So I think that's been an important aspect of what we do, and that often sets us apart from what others do as well.
I know you mentioned in the last Facebook Live that sometimes the muscles and joints can be almost harder than the bone
Absolutely.
part of this. I found that really interesting.
Yeah, I mean, you can lengthen a bone as much as you want, but obviously it's the muscles and the nerves that, and the soft tissues around the bone that are the limiting factor. Which is why we have to go very slow and be very, very diligent about maintaining range of motion and strength, so as not to compromise the joint. So if you're lengthening the thigh bone, the knee is at great risk for becoming stiff. It can even come out of place, and that's a horrible complication to have, and fortunately it's exceedingly rare. But the key to protecting that is daily exercise, daily therapy. So you can imagine that there's the importance
Right.
of having the patient engaged on that on a daily basis.
Well, I think to kind of wrap things up, is there anything that you would want people to know if they'd never heard of this? I'm sure a lot of people watching maybe have never heard of this type of a treatment that you tell people, or?
Well, it's good to know that you have options out there, and the options don't have to necessarily be external fixation. And for each person, it's very individual. And there are times where we have no choice but to do external fixation. Certainly, the goal of the research that's going on right now across the board is how can we correct deformity and lengthening without having to use an external fixator. Because anytime we can either not use it or shorten the time in the external fixator, that's very, very helpful. But this is definitely an option for a lot of people, and as the technology gets better and our understanding of how to use it, even for deformity correction, I think it's going to open a lot of doors for a lot of people.
That's great. Thank you so much. Fascinating stuff with Dr. David Podeszwa. Be sure to join us next week. We'll be back with another episode of SRH Access Live.